I mean, it has gotten a lot better. So, I mean, when I first started, um, there was no photography even, right? I mean, we just had the clinical eye, and then you basically jotted in your note, what a lesion looked like. But in individuals who had, 100+ lesions, it was impossible to write down the morphology of every lesion. And again, words don't really describe what the lesion really looked like and whether it had changed or not. And one's memory is only so good. So initially on, it was Polaroid photos were taken of individual lesions. Kodachromes that were then projected on a rear view projector were used. Obviously, enter computers, and then now we were able to digitize the images and have them projected on our computer screens to compare to. So that whole technology of imaging lesions in dermatology, whether it's nevus or even psoriasis, that has evolved quite significantly. And now even to the point where, computer algorithms, artificial intelligence is being utilized to evaluate those images. So you can actually use artificial intelligence to extract information off of the lesions that are imaged and have some input from an artificial intelligence perspective as to whether something may be concerning or not. So I think that has evolved. And then in addition to that, monitoring has also evolved in that, yes, you can take serial images, and then those serial images can be evaluated by the clinician, but it can also be evaluated by artificial intelligence systems, right? So you can have two images of, let's say, the back, and then have the computer go to work to highlight all the lesions that are new or that have changed, thereby hopefully streamlining the work that the clinician has to do. So on follow-up, you kind of just concentrate on the ones that are new or changed as opposed to the ones that are stable. So yeah, lots of evolution on the imaging front, on the clinical and the dermoscopic imaging front. Obviously, there are lots of evolutions also on imaging front on a morphologic level, on a cellular level. So confocal microscopy can evaluate on the cellular level and see the morphology of cells. So think of it like an in vivo biopsy. And that has improved our diagnostic accuracy as well. And this technology continues to evolve. So yeah, lots going on in that field. Yeah, so I think there are multiple ways of thinking of artificial intelligence. So a lot of people are sort of after this, whatever, holy grail that you can one day take a lesion, an image of a lesion, submit it to AI. AI will evaluate, and it will be better than any human being can be and provide you with the answer. And that's sort of what I call the easy button, right? So there's no more thought involved, and the physician is free to go do whatever else they have to do. I don't think that that's realistic, nor do I think that's going to happen in the near future. I think if people were to rely on that, what will occur is, yes, you will find the cancers, but in the process, you will also be removing a lot of benign lesions. So while AI sensitivity can be quite good at melanoma detection, on a mass scale, the specificity will prove to be poorer than that of the clinician. But where I do think that AI will make our lives a lot easier is, for example, if I have a patient that has 500 lesions on the skin, I can have total body photography done, and then AI can extract all of the lesions off of the skin and evaluate them, and then create risk bins, let's say. So maybe there'll be 20 lesions that are at highest risk for not being melanoma, that if there is a melanoma, it will be in that high risk bin. All right. So instead of having to look at 500 lesions, perhaps you only have to look at 20. And if there's a melanoma present, it'll be within that high risk bin. So kind of, cutting down on the number of lesions that you have to see. So if AI is 100% sure that it's benign, we can weed those out. You can also go one step further that, if AI can let's say create this bin, and as an example, I said, it picked 20. Well, let's then take those 20 and take dermoscopic images of those, and then feed those through AI. And now AI will weed out again all the benign lesions and leave you with a group of lesions. Maybe it'll be 5 that it feels are atypical. And now those 5 are the ones that end up on your desk. On this hypothetical scenario that I portrayed, we started with a patient with 500 moles. AI extracted them down to 20, and then dermoscopy whittled that down to 4 or 5 lesions. Those 4 or 5 lesions will end up on the desk, or not on the desk, or on the clinician's attention. The clinician will then evaluate those 5 lesions, and at least the hope right now is that if there's a melanoma present on this patient, it will be within those 5 lesions. And then all the others can be pretty much ignored. So that is I think the direction more likely that AI will be utilized, at least in the management of patients with lots of nevi and dysplastic nevi.